Good morning, everyone. This morning we're going to spend a few minutes together going over the final rule with comment period. So for folks that aren't familiar with what that means, we'll have a disclaimer and review that. Here's our agenda. Very quickly, we're going to go over the who, what, where, when, and go over how the program has changed. I don't know the level of program interests that you have based on the attendees and the topic of the conference. I think there'll be a little bit more questions and interest in the payment applications or implications of the program. And I know that there have not been a substantive grouping of details that have gone out about that, so we are aware at CMS that that is something that is anticipated and needed. We are working with the Medicare administrative contractors over the next couple of months to make sure that that information is provided. And then there will be education and outreach materials that will provide some specificity to that. And we can talk a little bit about that at the end, but again, the primary purpose for the briefing today is to go over the year 2 impacts. And I'll try and get a halfway gauge of interest somewhere around the 10-minute mark to see if this is still of interest. So if eyes are waning, I might do a hand call or a hand wave, and if you want me to move on, just go ahead and say, let's move on. I know you got a lot going on and it is early. So we can do the Q&A. The only challenge with the Q&A is we have a final rule with comment period, so regulatorily, statutorily, we have obligations on what we can and cannot do for that, and that's what you hear on the screen. So very quickly, our overview. So for folks that are unfamiliar, the Quality Payment Program was authorized in 2015 and requires an implementation of incentives that are combined into the Quality Payment Program, which covers advanced APMs and MIPS. I specifically work in MIPS, and based on what the statute and what Congress had provided for us, MIPS's purpose was to help support the transition into APMs. Our considerations, so these are the things that we focus on at CMS as we try and implement a program and make sure that we have continuity for the clinicians and groups that are across the country. I would highlight beneficiary outcomes and reducing burden on clinicians are the new priorities. So reducing burdens, you'll see in the year 2 rule, takes a different impact. So there's the burden to the clinician that we tried to account for in different capacities, and then burden to groups also in different capacities. And that's primarily around small practitioners and small groups. So they have a little bit of lowered requirements or reduced requirements. But I think it'd also be helpful for this audience to understand a little bit about how decision-making with the business relationships change the policy. So there was a definitional change on what we use for a low volume threshold, and that partially came from billing. So our merit-based incentive payment system. Again, I'm the scoring lead, so what that really means is my job is to make sure everybody that is in the program gets the right number that is part of the performance, and that number translates into a payment adjustment, and the payment adjustment is what is applied 2 years hence. So for the 2017 performance period, the 2019 payment adjustment is what we will determine in about March or April of 2018. So there's a 2-year stagger for how it applies in MIPS. So again, for folks not familiar with this, MIPS was a combination of 3 different programs that Congress in 2015 said combine, kind of sunset these programs and re-implement something that's a little more streamlined and less burdensome. And those programs are PQRS, the Value Modifier Program, and the EHR Incentive Program for eligible clinicians. This is a kind of a breakdown of how the math at a high level works. So essentially, in 2018, there's 4 categories. In 2017, there were 3 categories that were composed for your final score. And this roughly parallels to the slide I just reviewed, which was the quality category was what was formerly known as PQRS. The cost category would be the value modifier program components. And advancing care information was the EHR incentive program. The new category that we had started in 2017 is improvement activities. So these 4 performance categories are still carrying forward in 2018. However, cost does have a weight. So weighting, when we get into calculations, means it bears some impact where formerly it bared no impact. And in the cost category, there are two measures that are relevant, which is the Medicare spending per beneficiary and the total per capita cost. So those are the two measures in the cost category that I think may be of interest to the group today. Overall, the final score is compared to the MIPS performance threshold to determine if you use a positive, negative, or neutral payment adjustment. And that is on a scaling factor of a +5, -5 for year 2. So if you are a negative, that's a -5%. So what that means is on your paid amount, if it was $100, you would get 95. And if it was a positive adjustment, if your paid amount was $100, your positive adjustment would be $5. If you had both scaling factors maximized. It's a scaling factor, so on the positive side, it starts at 0.011 and moves up to 0.05. So I'll say that again. The payment adjustment is positive, negative, or neutral. The negative is 5%. The positive is 5%. It's a scaling factor, so if you think about what happens, non-performers and the additional adjustment, basically the bonus money, is redistributed on a scaling factor for positive adjusters. All right. So we just started rolling out these materials for year 2 because the final rule was published literally a little over a week ago. So, all right. So year 2, who's included? And this is, I kind of put a little teaser on this just a minute ago. So the difference is no type and change of clinician, which includes the members of this organization. However, they are not on the slide, but they are on this slide. So again, no change to the types of clinicians to include the members of this organization. On slide 13, this is where I want to make sure that understanding the levers of policy, how that changes the program. So we changed the low volume threshold to include MIPS eligible clinicians billing more than $90,000 a year in Medicare Part B allowed charges and providing care for more than 200 patients a year. So one more time. MIPS eligible clinicians billing more than $90,000 a year in Medicare Part B allowed charges and providing care for more than 200 Medicare patients a year are in the program. That is a very big increase from what was in the program last year. Would also highlight that voluntary reporting means an option for those clinicians who are exempt previously. So voluntary reporting means we know you bill CMS, CMS has your claims. If you use quality data codes on claims forms, those are coming in. I know for a fact in 2017, last time I checked, there's like 280, 300,000 plus clinicians that still use claims. So you could still be a voluntary reporter based off of a relationship you had with your biller from PQRS and value modifier time period. Some clinicians are in that relationship. So they would still be considered reporting, but they would be qualified as voluntary.
Great. And
not eligible for a bonus or a negative adjustment.
Yes, and I bring this up, this is very important because private insurance companies are going to look at MIPS scores for financial credentialing. You might find that all your patients have a higher copay if your MIPS score is low or you don't have one. Does everybody understand that? Come talk to me after.
All right, follow-up question to Dr. Dollard.
Yes, sir.
We were discussing this last night. So if you have a doctor that works for different groups or is part-time,
yes,
and they meet that exemption, they're billing for different groups, do they qualify? They're seeing fewer than 200 beneficiaries, or their rate, or billing less than $90,000 in approved Medicare charges in different groups. Mm-hmm. They may, their lump total, some of billing to Medicare may well exceed $90,000.
They themselves,
but they're billing under different tax ID numbers.
Yeah, they themselves would be identified as eligible. I don't know what the system logic would ascribe to them for their primary TIN where they would determine eligibility. It would probably be the TIN where they bill the most.
Thank you.
So this is the change slide that we just talked through. Again, basic exemption criteria. So, and this is important to note for particularly where was the gentleman who was talking about the people joining groups in his state? So enrollment is a factor below the low volume threshold, and if you're in an APM, an AAPM, you're excluded. The other element is for people who read the rule and understand the logistics of implementing rules across the country carefully, there is eligibility determination periods. So there is also a window where clinicians may be excluded if they join after a certain date. And that would be the same factor as what you see on your left-hand side of the screen, which is newly enrolled. So if you change practices on December 31st, 2018, CMS probably won't know that in time for MIPS reporting on 2018, which starts January 2nd, 2019. Does that make sense? That is a factor we are trying to account for, so those clinicians that fall into that bucket, if they're changing practices very late in the year, would have an exclusion that would be similar to newly enrolled. So they're exempt under that ID if it is not already eligible. So if they're joining a TIN that's already eligible, that TIN reports, that group reports. If they're joining a new TIN, it's the same as newly enrolled. Yes, ma'am. That's okay.
Are we talking about a 2-year period of time for this exclusion? For example, if someone wants to claim the exclusion in 2018, is it that $90,000 threshold in 2017 or 16?
Yeah, it's a great question. So let's back up one slide. So the eligibility determination is essentially the the beginning of September 2017 to the end of August 2018. That's an eligibility determination cycle. It precedes it. So we have to do an eligibility determination when we do our rulemaking. So we did our eligibility determination for 2018 performance in 2017. We do another follow-up reanalysis to make sure eligibility is still accurate in 2018 along the same time frame. So yeah, there's two numbers. So year 2 performance, as in when do we determine these numbers, we started in the first look. The first look runs through claims analysis from the first day of September 2016 to the last day of August 2017. The second look for year 2 performance occurs covering our 2017 to 2018 cycle, same dates. Does that make sense? Okay. There are options to do further analyses, but again, if that is something that would be helpful based off of the challenges and work that you guys focus on, I would defer to your organization, but we can talk about how to put a comment in the rule on those determination periods. And they're easy to find if you know how to search a PDF document and are not intimidated by 1,100 pages.
So for the threshold, in the final rule, it says 90,000 in allowed charges. And this says 90,000 in billing, so a question we get from our members a lot is it the allowable?
It's allowable.
So it's not what we bill.
So it depends on what people define as bill. So different organizations call billing different things. We can
Right.
change that on the slide if you want.
Thanks.
It is allowable charges, though, just to reconfirm for you.
Is the 200 patients, is that encounters or 200 separate patients?
It's 200, I'll have to follow up on that one. I think it's 200 unique beneficiaries. It's unique beneficiaries to my knowledge, but I don't know if there is a change with group reanalysis. So this is a non-patient facing. For our purposes today, this does not apply. I would highlight though, application of virtual groups. I don't actually know the billing and clinical practice patterns of podiatrists, so I don't know if they primarily work independently or not. We can talk about virtual groups for a little bit, but virtual groups are primarily to help clinicians that are small that wouldn't have access to a group otherwise, to have access to a group if they want to identify with a group in a virtual relationship. So there's no geographic restrictions. You can combine TINs within certain requirements. So that's what we have on the right side of slide 15. And this just talks about non-patient facing also applies to virtual groups. Other statuses, small practices are consisting of 15 or fewer eligible clinicians, and rural health professional shortage areas, or HPSA, or rural areas, would be those with 75% of the NPI's billing under individual MIPS clinician groups 10 within a virtual group in a zip code designated as a rural area or HPSA. So this is the performance period. Our change primarily, when you look left to right, is cost inclusion and the flexibility of the transition year, which had another challenged message, which we called Pick Your Pace, which said they could contribute one time or up to 90 days or for a full year. It is now for a full year in the quality category. So here's our timeline. And we've referenced this a couple times, but this kind of spells it out pretty clearly. So the performance period is January 1st, closing December 31st of 2018. The submission window ends around March 31st, 2019. There'll be feedback available sometime after that. Usually it's in around July. And then the payment adjustment starts on January 1st, 2020 on their next Part B claim. Reporting and data submission options. Individual, group, or virtual group, and I had highlighted briefly, virtual group is for solo practitioners, groups of 10 or fewer eligible clinicians who come together virtually with no specialty or location exclusions to participate in MIPS for the performance period. We have an election process that for your clinicians that may be interested or are considering it. There's a toolkit on our resource page that lays out what is required. There are some contractual challenges that people have asked for that we have tried to provide enough guidance on how to do that. We just covered this. Again, a group that has 10 or fewer eligible clinicians exceeds the low volume threshold at the group level. So I think that is, again, the factor a couple of folks have raised. When NPIs or clinicians combine, that would put the TIN or the group above the threshold. All right. So our submission mechanisms. Just as a show of hands for folks in the room, do the podiatry clinicians primarily use claims, or do they use, I would assume, claims? Yes?
Most are using claims.
Okay, that's what I assumed. Okay, thank you for that. So what's important to note then is the administrative claims for the cost category. So if they have a relationship, when we get into scoring, I'll talk a little bit about it. But the bottom two categories here lay out what I would consider active submission for the purposes of the podiatrists. So they would have to do some attestation on a CMS website. They could use any of our other options to submit as groups or individuals. The first two categories, if they're using claims with their biller relationship, and that is auto-applied with the quality data codes, and we can talk about CARC and RARC and all that other stuff if you guys want to go that path. But administrative claims would also be calculated for the cost category. I will also highlight that for groups that are 16 or higher, there is an all-cause readmission measure auto-calculation which comes from administrative claims. Okay. Our performance categories in MIPS year 2, our quality category lost 10% of its weight, so it went from 60% to 50%. Again, the purpose here is, as highlighted, burden reduction. So we have a small practice that allows them to receive 3 points if they didn't meet data completeness. So is there any interest in understanding data completeness? Does that, if I say you need to send 20 encounters and our previous data completeness said 50%, that means if you had 20 encounters, you need to report on 10. Now it's 60%, so if you had 20 encounters, you need to report on 12. If you fail to meet 12, you fail to meet data completeness. That's pretty straightforward. It is something that I know is harder for folks that use claims because sometimes there are claims that are missed. But I'll pause there to see if that has any follow-ups. All right? Okay, moving on. So our scoring components, there's a 3-point floor for measures scored against a benchmark. I think that's probably out of scope for this group. I do spend a lot of time talking to methodologists and statisticians, and we can go into that if there's any in the room. But the points that don't have a benchmark get 3 points, essentially. Bonuses are available in the quality category, 10% of the denominator. So if you had 6 measures, your denominator is 6, which gives you 6 bonus points. Bonus for end-to-end bonus, again, 10% of your denominator. So if you had 60 points total, 6 points is your bonus there, so 6 and 6, all right? No change for 2018. This is the cost category. So in 2017, we had the 10 episode grouper measures. Those are not carried forward. We do have 2 measures, and we are developing new episode-based measures with significant clinician input. I believe we had over 100 specialties working on these episode measures. And we will allow clinicians to see their cost measure scores before the measures are potentially included in the MIPS program for these new episode groupers. And as I had mentioned before, the Medicare spending per beneficiary and total per capita cost measures are included in the program. And these measures were used in the value modifier program. I know that the value modifier program methodology was hard to dig into for a lot of folks. We will try and keep the MIPS materials as reader-friendly as possible. So I understand that that is a comment that I would expect. We expect that all the time. So, all right. So for the cost category, each individual clinician's group and cost performance will be calculated using claims, and individual MIPS clinicians and groups are not required to submit any additional information. I'm basically remessaging what I said about 3 minutes ago. I would note, if only one measure can be scored, it will serve as the performance category score. And the performance category score is the average of the 2 measures. So scoring improvements for quality and cost. So this is part of what Congress gave us with MACRA. We need to measure improvement. And improvement scoring is based on the rate of improvement, with higher improvement results in more points for those that have not previously performed well. So for example, if the category in 2017 gave you 50 points, you scored 30 points. In 2018, the category gives you 50 points, but you scored 40 points. There's a demonstrable increase in performance, both at a category level and at probably a clinician actual performance on the measure level. So up to 10 points are available at the category level. For cost, because cost is weighted at 10%, the percentage point available is only 1%. So again, if you think back to the first level set of math, cost was 10 points to your final score. So your improvement score for cost would only be 1 point. Improvement activities. Just if anybody could shout out, I don't actually know that we've had a session with the podiatry clinician groups, at least not in a smaller setting such as this. Are there improvement activities that you are challenged with or you find do meet your needs? We would want to hear from you on that. Again, with that burden reduction aim. The small practices really only have to demonstrate doing 2 improvement activities to achieve the highest score, so that's 15 points. And it is all by attestation. So there is no numerator denominator, there is no claims or billing relationship calculations, there's no, did I put this in the chart? It's simply, do you do patient safety sessions? Do you have after hours care? And do you do it consistently on a regular basis that we could identify for 90 days? So do you do it on Fridays? Yes. Do you do it on every other Friday? Yes. That's an improvement activity that's outside of the clinical patient provider relationship that improves the care. All right. So I'm not going to spend too much time focusing on these for the moment. All right. So we do get a lot of questions about advancing care. Again, with the burden reduction, there is a lot of flexibility with the 14 or 15 cert still allowable in 2018. There is also a 10% bonus for 2015 cert. There's no change to the base score. The base score is it's a little hard to fathom for some people when we brief it because it exceeds 100 points. So, and then bonuses take it above 100 points. So I won't spend too much time talking about performance in the ACI category unless there's interest. This is important. Exceptions based on the authority in the 21st Century Cures Act, CMS will re-rate the ACI category to 0 and reallocate the performance category to 25% for the following reasons. If they're hospital-based, ASC-based, nurse practitioners, PAs, clinical nurse specialists, or certified registered nurse anesthesists. There's a hardship exception for clinicians. That is the same hardship process that is currently in effect for our current year. So there's a website where you can put in your hardship request. The deadline is December 31st for the performance period and the submission of hardship applications for 2017. Finally, we revised the definition of hospital-based clinicians to include place of service 19. So the performance threshold and payment adjustment, and this is what I think we wanted to probably spend most of the time talking through if we hadn't already touched on the questions previously. So the increase in the performance threshold and payment adjustment. So if you think about a data model and we say we change the composition of who is in our program, if you think about a pool of water, we've raised the limits, so we removed some portion of that volume. So when you move the volume, the expectation is you could also change other expectations of that population. With that, we moved our performance threshold. If you think on a scale from left to right, left being 0, right being 100, we went further to the right. We went from 3 to 15. There were a lot of comments we received on this because it is changing not only what is expected, but also who it is expected of. So I'll pause to make sure that that kind of makes sense to the group. So that's what you see there with your 3-point threshold to a 15-point threshold. The exceptional performance, which is where the additional payment adjustment is provided, still stands at 70 points. And the payment adjustment set at plus and minus 5%, which I hopefully messaged at least twice. That was my purpose earlier. So how do you get 15 points? This is, I think, probably useful to your members if they're trying to understand how to participate and at least get a neutral payment adjustment. They could report all the improvement activities. So if they're in a small practice, remember, reporting all the improvement activities is simply saying yes to activities that are applicable to them. They can meet the Advancing Care Information base score and submit one quality measure that meets data completeness. They can meet the Advancing Care Information base score by reporting the 5 base measures and submit one medium-weighted improvement activity, or they could submit 6 quality measures that meet data completeness criteria. Hopefully that made sense. We can go through the 15 points. There will be additional materials that provide a little bit visual representation of that last element in the future. So the increase in the performance threshold and payment adjustment, again, this is just another look at it. If you're looking at that scale that I just talked about from left to right, this lays it out pretty clearly. And the only thing I would highlight is the eligible exceptional performance bonus minimum is a 0.5% at 70 points. So if we go back to our, one of the original kind of descriptors I had set was up to 5%. So if a clinician had a 2.5% because they scored 71 points, it's 2.5%. But that 0.5% becomes based solely on the points that they hit, not the scale. So there's a redistribution scale, but there's also a bonus that kicks in when they hit the 70 points. And that, again, for folks that have read the statute and understand this, we usually get a lot of questions around this. So Congress every year appropriated $500 million to make sure that that 0.5% bonus is always there for folks that reach it. So you may have bonuses depending on the performance and the total number of participants in the program with the description of the volume that I just provided. The redistribution of funds is from the non-performers to the performers, but Congress also said for those that exceed the threshold, they would always get a bonus of at least 0.5%. Any questions? That's a little bit of nuance, and the reason I am going a little slower, and I know it's probably a little laborious, we've seen a lot of materials from a lot of organizations, and I have not actually asked for our communications team to check any of your materials. but they have promised very high bonuses. For folks that are familiar with the value modifier program, there were very high bonuses for exceptional performers, up to 18%. That's pretty high. But for the purposes of the MIPS program, those bonuses are not expected to be that high, given what I just said about the 5% scale. So just wanted to re-emphasize that. All right, so scoring. This is predominantly where I work. I won't spend too much time here other than to say the MIPS final score is compared to the MIPS performance threshold to determine if you receive the positive, negative, or neutral payment adjustment. And we have we have additional scenarios for hardship due to natural disasters that put people at the neutral payment adjustment because they are automatically set to the performance threshold. So kind of a do no harm because of impacts from disasters for the program. There's additional bonuses. I don't know that I would expect there would be a lot of interest in this, but I would just quickly share. So there's 5 bonus points at the category, above the category level, so this is your final score level, which uses hierarchical condition category risk scores, which was used in the value modifier program. However, to get this additional bonus, clinicians must submit data on at least one performance category in the applicable performance period to earn the bonus. So this is an auto-calculated bonus similar to your administrative claims. And this is looking at what the clinician treats both in a dual eligible, so Medicare and Medicaid beneficiary count, and it also looks at the complexity of the patient using these hierarchical conditions. So what is the risk factor associated with taking care of patients? There are some that are more risky and some that are less. And so to account for that within the program's performance, we also don't want to disincentivize clinicians to treat patients. And we also do want to incentivize them, so that's the purpose of this bonus. It might be a little granular, but it is relevant to a lot of folks that are challenged by this factor. Small practice bonus is added to the final score for any MIPS eligible group who is in a small practice of 15 or fewer clinicians, so long as the eligible clinician group submits data on at least one performance category in the period. And this is a recognition of challenges for small practices within the program. As we change that mix of volume in the total program, there are still those that are disadvantaged for different reasons. So this is an element to provide a little bit of a top up. This is probably not relevant, but I'll briefly highlight it. For facility-based measurement, we have a 1-year delay. Facility measurement uses other value-based purchasing scores and translates them into MIPS scores. So for clinicians that work in hospitals, such as a hospitalist, we would take the practice that they work at based on their CCN or their hospital, which has a score, and move that into MIPS. All right, so this is the extreme and uncontrollable circumstances I had just messaged a couple slides ago. So within our interim final rule, we have an automatic and extreme and uncontrollable policy where clinicians are exempt without submitting a hardship exception application. What does this mean? It means we will automatically reweight quality improvement activities and advancing care information categories. It will result in the clinicians receiving a MIPS final score equal to the performance threshold unless, and I say just one more time, unless the MIPS eligible clinician submits data. Clinicians that do submit data as an individual group will be scored on their submitted data within certain criteria, and this policy does not apply to APMs. So I'll pause there. This includes everything that is listed on the CMS website for natural disasters, which right now covers the hurricanes, and I think is also going to be covering the wildfires. I haven't checked recently. Wildfires in California. All right, so year 2, this policy is essentially what I just laid out and will also apply in 2018. So the hardship exception application is required to be submitted though, and the deadline for that submission is the end of 2018, so the end of the performance year. All right, so final elements of seeking comment. So we finalized many of our proposals, but we do have several items as noted below. Oh, sorry. I'm trying to see if there's any that are applicable to the group here today. I think the low volume threshold we had talked through would probably be relevant, and they highlighted the methodology for me, but I don't think that that's necessarily relevant unless anybody has elements to that. But we do have an open comment period on these items, And that pretty much is something that I think we would hope you work out with your association, but we do invite comment from anyone in the public, any stakeholder. I do know that the materials for the association were up to date and did actually highlight the year 2 final rule, which was very, very, very much appreciated. So our help and support. So for specialists and large practices and small practices, we have a variety of elements. This is available on our website, and I think we'll be able to pass this deck out with the session if it hasn't already gone out. Okay, so I know we did a rolling Q&A, so I don't want to pause. I don't know what's next on the agenda, and I don't know who's next on the agenda, so I want to be respectful of everyone's time. If you have comments that are not associated with these topics, we can talk about it. If you have comments associated with these comments, or with these topics, I can listen, but I cannot respond with like an operational or a business response. What are the implications of that? I can't really reference these. These would need to be in our comment rule by law. So with those ground rules, if there's anything else, I'm happy to hear from anyone or take any questions.
Thank you. That was very helpful. Thank you.
Okay, great.
So on your list of things you said you could listen, the scoring methodology, this might fit in there?
Yeah.
So cost is in the final rule now, as you covered. The proposed rule very clearly said that cost would not be included. And what we're going to hear from our members, and what I'm looking for help from you with, is what our members are going to say, right? So everybody thinks they have the worst patients, right? Sure. Every specialty thinks that,
sure,
including us.
Sure.
So we think we have a large diabetic population, they don't eat well, and they incur large costs.
Sure.
So our members are nervous about the cost attributable to the system by our patients, and fearful that we're going to get docked for behaviors that we have no impact on, right? They make bad decisions that land them in the hospital, that incur large costs.
Yeah.
And so I guess, you know, and I know some of this you said you can just listen to, which is fine. So that concern, the cost, and then the other one with, we had the proposed rule for months that said no cost, and then we got hit with this on November 2, which if there is anything we can do to prepare for that cost thing, we were only given 7 weeks to do it.
Right. So what I can share is, so it was part of the rule. There were a variety of options that were laid out with the notice for proposed rulemaking. It's against the actual law. What we're talking about is a regulation and policy, but it would be against the law for us to incorporate something that wasn't already in policy as a proposal in this year or in previous years. And so the 10% was on the board with the year 1 rulemaking. It would carry forward. So the reason it is implemented, to be very succinct, is the statute requires us to go to 30% in year 3. We don't want to create cliffs. To the extent we can, we want to mitigate those cliffs where clinicians suddenly have to say, well, it's no longer something I really control, as you've just described. But that would be that is the law. So Congress gave us that in the statute. Unless the statute is changed, that's what will happen in year 3. To mitigate that, our, as in CMS and the leadership process, as in took a path to make sure that those cliffs would not be so steep, if that makes sense. That's why policy is an instrument of politics, all right? So that's number 1. And then number 2, the most helpful thing may be to just do the back of the envelope or the napkin tablecloth math. The cost category is 10%, and I just told you we have a bonus of 3% that's at the top of the program. Even if you do poorly on that, there's 10 points available to your final score of the 100. I just told you you're probably going to get around 3 points for the same administrative costs. It's not necessarily balancing out the MSPB measure with the hierarchical condition categories, but that's the same kind of balance that the value modifier program did. That's number 1. Number 2, there's also the small practice, and I think that most of the clinicians in this specialty are in the small bucket. So that's also 5 more points automatically applied to them if they were reporting satisfactorily on one of the categories. So we're talking about 8 points. And that's the whole purpose of mitigating the cliffs. We're going to have better materials. Some we can't provide, some we can talk through, but that's the relationship. So it is the least burdensome path to the path we have to take. All right.
Just a clarification.
Yes, sir.
Regarding the advancing care information.
Yeah.
Where it comes to the hardship you'd mentioned.
Yes.
With small practices or physicians 15 or less
Yes.
practice. The points attributed to that can be reduced to 0 from the
Yes. So yes.
But that what would happen is the quality measures would then raise from 50% to 75%.
So the reweighting, I don't believe it's 60. I don't think it's. I have to check the math again, but it's not 75% for the quality category, because you still have the cost category and improvement activities.
Gotcha. But the so that
Let me go
but
back
that
to the
was
right
for.
slide.
Was that 25%?
I think it. Yeah, it's 25%. Yes.
So that 25% would go to quality.
Yes. I'm trying to find the slide for you. I'm sorry. I'm not very good with the. But yes, it does. It is what we call reweighted.
So that that 25% would go to quality. So the quality would go to 75%. Correct?
Yes, because it's the improvement activities is still 15%, and the cost category is 10%.
Thank you.
So we do tend to get follow-up questions on reweighting that go a little bit beyond that, but I'll pause because I think. Go ahead.
John actually stole my question, but I just wanted you to elaborate on that scenario where that reweighting would occur.
Yep. So the purpose of the reweighting is the statute, as in what MACRA Congress gave us in 2015, requires a composite score. So legally we have to have a composite, means 2 items together. It's not, we can't base your performance on one category for the MIPS program. So we have to have at least 2 categories. So when we reweigh you, you would still have 3 categories available and applicable. And for the clinician, again, for the specialties that we're talking about today, they do have measures available and applicable. There are some specialties and some clinicians that practice in certain ways where they don't always have measures available and applicable, but that's not necessarily the case. So some people would say that the quality category does not apply to them. But that is also factored into the reweighting. So you could reweight the category all the way to cost and improvement activities if you went one more round. We have lots and lots of regulation text on that. It's not easy to read. So hopefully that all made sense. All right.
Do you have any information on the study group that CMS is doing right now on the patient over paperwork initiative?
So the patients over paperwork is part of the larger burden reduction process, and within the part of CMS where I work, it's called meaningful measurement, and I unfortunately do not have information readily available to provide that to you. Some of it we reference in the program as part of what the goals are, but in terms of what the tangible prospects or operational things you can engage on are, I don't have any provided, but we can follow up to, I'll make sure our communications folks provide those.
Okay, thank you.
You're welcome, thank you. Okay, any last questions? I actually don't know what time it is, but I think I'm under time, so. Yeah. All right.